Greetings. My name is Julia Schillinger. I'm in the Bureau of Sexually Transmitted Infection Control at the New York City Department of Health and Mental Hygiene, and I will be speaking about making neonatal herpes reportable in New York City. For today's talk, I will start by giving some background on herpes simplex virus, specifically the biology and clinical manifestations of genital herpes disease. And I will describe the epidemiology of genital herpes and neonatal herpes. I will then move on to considerations in making a disease reportable and how those considerations apply to neonatal herpes. I will then talk about the process and rationale for making neonatal herpes reportable in New York City and present some select findings from surveillance for neonatal herpes. There are two herpes simplex viruses, herpes simplex virus type 1, or HSV1, and herpes simplex virus type 2, or HSV2. These two viruses are double-stranded DNA viruses, and they are characterized by their ability to establish latency, which is asymptomatic infection, their attraction to the central nervous system, or the damage they can wreak there, which is neurovirulence, and their capacity to reactivate after periods of time where they are completely inactive. This is a cartoon that shows the pathogenesis of either herpes simplex virus type 1 or type 2. If you look at the top figure, what it shows there is that virus will be inoculated at a site on the skin, and there will be replication of the virus at that site on the skin. But the virus will then travel up a peripheral sensory nerve. You see the virus with the arrows indicating the direction of travel, and it will travel up to a dorsal root ganglion. Dorsal root ganglia are clusters of nerve cell bodies that run alongside the spinal column on either side of the spinal cord. And it will establish latency, that is sort of a dormant state, in that dorsal root ganglion. If you look at the lower figure, what you'll see is that while it can establish latency, it can also replicate there. And at some period of time, after the initial infection, if there is a reactivation, virus particles will then travel back down the peripheral sensory nerve and actually cause disease at the same site on this body, at the same sort of patch of skin where infection was initially inoculated. Now I want to say a few words about the clinical manifestations of genital herpes infection. And before I describe those, I want to say first that historically, infections, as we used to say, above the waist were caused by herpes simplex virus type 1, which would cause oral lesions. And infections below the waist would be caused by genital herpes virus HSV2. That is changing a great deal now, and we are seeing infections caused by HSV1 occurring in the genital region. But the most important thing to take away is that most herpes infections, and I'm going to focus on genital herpes infections because they have direct bearing on neonatal herpes, but most genital herpes infections are completely asymptomatic and unrecognized. And that is really how these infections have become so highly prevalent in the population. They're passed between people who don't even know they're infected. So most infections are not recognized. However, if there are recognized clinical manifestations, they are classically these clusters of very small, painful, blistering lesions at the site of inoculation. There are also atypical symptoms that can occur, and these may be things like recurrent vaginitis or urethritis, tingling, pain, and fissuring. This is a picture of some classic herpes vesicles, which is what the lesions are called. And you can see here, I think quite clearly, these tiny, maybe a millimeter diameter for the small ones, clusters of lesions on a red base. Genital herpes infections are highly prevalent in the United States, and there's some regional differences in the prevalence. Historically, as I mentioned, most genital herpes infections are due to type 2, HSV2. However, HSV1 is an increasingly common cause of new genital herpes infections. Most genital herpes infections are unrecognized, as I mentioned, and asymptomatic shedding is common, again, contributing to ongoing transmission in the population. To give you some sense of how common genital herpes infection is in New York City, these are data from a survey conducted in 2004 in New York City, the New York City Health and Nutrition Examination Survey, which was modeled on the National Health and Nutrition Examination Survey, also known as the NHANES. And what you see here is that 71.1% of New Yorkers aged 20 and older had antibody to HSV1, and 28.4% had antibody to HSV2. Now, it's important to realize that, if I haven't said this already, that herpes infection is lifelong. So the presence of antibody is indicative of past infection and the capacity for asymptomatic shedding during periods of asymptomatic reactivation. The 71.1% of HSV1 antibody is probably largely oral infection in New Yorkers because HSV1 is most commonly oral infection. However, some portion of that is also genital infection. In contrast, the 28.4% HSV2 seroprevalence is probably almost all genital infection because while HSV1 can cause genital infection, HSV2 only causes genital infection. It does not tend to cause oral infection. So the 28.4% genital infection estimate here is probably a minimum estimate, and it translates to about 1.6 million adult New Yorkers with genital HSV2 infection. These data are also from the City Health and Nutrition Examination Survey, and they show that at every age, females have a higher seroprevalence, that is, prevalence of antibody to type 2 herpes, higher than men at virtually every age, and that the prevalence increases with age. Although you can see there's a plateauing and a dropping off in the older age range, and this is probably some sort of cohort effect where people that are currently 60 and older were less likely to have been infected with herpes when they were younger. These data, again, taken from the City HANES, show herpes seroprevalence by race, ethnicity, and sex among New Yorkers. And what you see here is most immediately is that in every subgroup, every race, ethnicity defined subgroup, women have a higher seroprevalence than men. But that also there are vast differences in the seroprevalence by race, ethnicity, such that white non-Hispanics have the lowest seroprevalence in both men and women, and black non-Hispanics have the highest seroprevalence of all these three groups displayed, with non-Hispanic black women having a 61% seroprevalence. These data are also from the City Health and Nutrition Examination Survey, and they show that at every age, females have a higher seroprevalence, that is, prevalence of antibody to type 2 herpes, higher than men at virtually every age, and that the prevalence increases with age. Although you can see there's a plateauing and a dropping off in the older age range, and this is probably some sort of cohort effect where people that are currently 60 and older were less likely to have been infected with herpes when they were younger. These data, again, taken from the City HANES, show herpes seroprevalence by race, ethnicity, and sex among New Yorkers. And what you see here is most immediately is that in every subgroup, every race ethnicity defined subgroup, women have a higher seroprevalence than men. But that also there are vast differences in the seroprevalence by race ethnicity, such that white non-Hispanics have the lowest seroprevalence in both men and women, and black non-Hispanics have the highest seroprevalence of all these three groups displayed, with non-Hispanic black women having a 61% seroprevalence. This slide shows the seroprevalence of HSV-2 antibody by race ethnicity and number of sex partners. And what you see here are vast differences in the seroprevalence in different subgroups defined by race ethnicity, stratified by number of lifetime sex partners, number of sex partners they've had in their life up until the point of survey. And so what you see is that among non-Hispanic whites, shown with the green line, individuals who've had 10 or more sex partners in their life have a seroprevalence that is comparable to the seroprevalence among non-Hispanic black New Yorkers who have had only one sex partner in their life. And what this probably reflects is differences in the probability of encountering HSV-2 in sexual networks defined by race ethnicity, to the extent that people have sex primarily in sexual networks of people like themselves in terms of race ethnicity, in terms of educational attainment, and so forth. But there are vast differences here in the risk of herpes 2 by race ethnicity. So finally, with that background, let's move to neonatal herpes. It's just very important to understand the epidemiology of genital herpes before you start to think about neonatal herpes. So there are three modes by which a newborn can acquire herpes. The rarest is to acquire it while still in utero, intrauterine infection. Or congenital infection is another way to refer to that. And that is the least common mode of transmission, and it accounts for about 5% of neonatal herpes infections. Most neonatal herpes infections are acquired during delivery as the infant passes through a birth canal where virus is being shed. And then approximately 10% of neonatal herpes infections are acquired after birth or postnatally. Now, we spent quite a bit of time talking about seroprevalence, and one reason for that is that the presence of antibody in a pregnant woman has a strong influence over the risk for acquisition of neonatal herpes if a woman is shedding virus at the time of delivery. The infants who are at the greatest risk for neonatal herpes are those who are born to women who acquire genital herpes during pregnancy, but who have not yet had a chance to develop antibody, which can then be transferred to the infant or the fetus at that point across the placenta. And so a baby is then born without the benefit of protective maternal antibody and exposed to the virus. About 2% of pregnant women who begin pregnancy without herpes will acquire herpes during pregnancy. And as I said, women with recently acquired herpes may not have yet developed antibody, and the infant then gets exposed during delivery. The risk for neonatal herpes is between 30 and 60% higher for infants who are born to women who acquire infection during pregnancy compared to women who enter pregnancy already infected with genital herpes. So knowing that women who enter pregnancy without genital herpes infection are at the highest risk, let's look at data also from the New York City Haines that looks at the seroprevalence of HSV-1 and HSV-2 and those who have no evidence of herpes infection, those in the last column, those who are seronegative for herpes 1 and herpes 2, and this is all among women of childbearing age. And what you see is that those that have the highest seronegativity, these are women Over here in the right column, let's look at non-Hispanic women. 38.4% are seronegative for both herpes 1 and herpes 2, and therefore, at some level, would be considered to be at risk for acquiring herpes during pregnancy. In contrast, only 13.9% of non-Hispanic Black and 9.5% of Hispanic New York women of childbearing age have antibody to neither herpes 1 nor herpes 2. Now, I will get back to those seroprevalence data among women a little bit later, but what I wanted to speak about here is the clinical manifestations of neonatal herpes infection. I mentioned that about 5% of infections are acquired in utero, congenitally, and those babies are born with all the stigmata of any congenital viral infection, including serious sequelae like microcephaly, which is a small head. The other clinical manifestations, 3 different ones I've listed here, that you see among infants who acquire herpes after birth or during birth and after, can be grouped as involvement of the skin, eye, and mucous membranes, or SEM disease, involvement of the central nervous system, or CNS infection, and then disseminated infection, which means infection that involves multiple organ systems in the body, for example, the liver and the lungs. That is the most serious and has the highest case fatality rate. The congenital infections, as I said, they're rare, about 1 in 300,000 live births, and are often fatal. Skin, eye, and mucous membrane involvement causes about almost half of all neonatal herpes cases, and if caught and treated at that point, there is little, if any, morbidity or mortality involved. Central nervous system infections, in contrast, which account for about 30% of cases, while they have a not terribly high case fatality rate of 5%, survivors are left with significant neurologic sequelae about half the time. And those disseminated infections, which I mentioned are the most serious, account for about 25% of cases and have a very high case fatality rate, 30%, although those that survive have a lower rate of neurologic sequelae than those CNS infections. So I know that was a lot of background, but I think it's very important to understand all of that in thinking about the considerations in making a disease reportable, in this case, neonatal herpes infection. But generically, there are a set of considerations in making a disease reportable, and they include the frequency of disease, the incidence and prevalence, the severity of a disease, what is the case fatality rate, how often is hospitalization required, does this disease result in a lot of disability and quality-adjusted life years lost. Then there's the cost. Is the disease in question something that has high direct and indirect costs? How preventable is the disease? Is it communicable to other people? And is it a disease of public interest? This is sort of the range of considerations. So let's start with the frequency of disease, and let's talk specifically then about neonatal herpes incidence and prevalence. Now, one of the challenges in knowing the incidence and prevalence of neonatal herpes is that it's not a reportable disease nationally, and it's reportable in only a few states. So we have limited data to look at that question. Also, the way this question has been examined has varied. People have used hospital discharge data. People have used data from sort of sentinel hospitals, but there's very little data. There are very little data from population-based surveys. So estimates range from as low as 11.4 cases per 100,000 live births, or 1 in about 8,800, to a high of 67 per 100,000 live births, or 1 in 1,500. We have data, it's shown in the second row here, that suggests that using hospital discharge data, which has limitations, but before we established surveillance for neonatal herpes, we looked at these data and we found about 13.4 cases per 100,000 live births, or 1 in 7,500. Okay, so the next consideration is severity. I think we have already talked about the case fatality rate associated with these different stages of or manifestations of disease, and they can be very high case fatality rates. So what about cost, direct and indirect, in the context of neonatal herpes? Well, the costs of neonatal herpes have been largely calculated in the context of studies that examine the cost effectiveness of potential prenatal serologic screening to identify mothers who are at high risk for acquiring herpes during pregnancy, that is, seronegative mothers. And there's been a range in the estimated cost to avert a case of neonatal herpes, ranging from about $144,000 per case to $2.5 million per case averted. These studies have used varying estimates of incidence, but 4 out of the 5 that I reviewed found that serologic screening was not cost effective. And there was the single study that did find it to be cost effective was funded and authored by industry, and so needs to be taken in that light. So now on to the question of the preventability of neonatal herpes. Well, to consider the preventability, you have to know what the risk factors are for neonatal herpes. One is vaginal delivery. Cesarean sections are protective, and this makes perfect sense because with a cesarean, there's much less likelihood of being exposed to vaginal secretions, although if the cesarean is performed after rupture of membranes, there may still be some ascent of virus into the uterus, so it's not completely protective. The second we've talked about at length, and that is primary maternal infection as opposed to recurrent infection during pregnancy. In other words, primary infection during pregnancy would translate some proportion of the time into the absence of maternal antibody, and we've talked about how that would be an increased risk to the infant. Prolonged rupture of membranes in a woman with herpes infection that provides time for virus to enter the uterus and cause infection. And then finally, any break in the integrity of the mucocutaneous barrier in the neonate, like for another name for skin, or mucous membrane breaks. And this can be things like invasive intrapartum monitoring with a scalp electrode. You will sometimes see babies that have clusters of herpes vesicles at the site where there was a scalp electrode placed, but also things like the practice of direct orogenital suction, which is a ritual Jewish circumcision practice known traditionally as mitzitza b'peh, and I will be talking about that. But that also involves breaks in the skin in the form of circumcision and then exposure to virus from the mouth of the ritual circumciser. So having described these risk factors, some of the prevention strategies are cesarean section, although not something you would want to recommend broadly. Another approach is to perform type-specific, these tests that differentiate between type 1 and type 2 herpes antibody, serologic testing during pregnancy, antiviral prophylaxis to prevent recurrence among women who are known to have genital herpes, to prevent recurrence at the time of delivery, so there's less likelihood that there'll be lesions present, and perhaps there'll be also diminishment in the amount of virus shed at delivery. Obviously, vaccine would be a major benefit to genital herpes prevention and prevention of transmission to the neonate. And there are various vaccine trials and vaccine development underway. An increased awareness of the prevalence of genital herpes and the risk for neonatal herpes infection among both patients and providers is another potential means of preventing some cases. And then reducing exposure to oral secretions during ritual Jewish circumcisions would certainly be preventative in those particular cases. In terms of the question of communicability, there is definitely mother or adult transmission to the infant, but there's little to no risk of transmission from the infant to others. And finally, the question of whether or not neonatal herpes is a disease of public health interest. Well, I and several others that work on neonatal herpes would certainly argue that neonatal herpes is a disease of public health interest. I will in a moment show you some data for physician visits for genital herpes, again, with direct bearing for neonatal herpes. There is a disease burden. It's not as high as some other conditions, but it's higher than some other things that we surveil for in newborns. There are really evident racial disparities in the prevalence of genital herpes infection, and that is, of course, of great public health interest. There are ongoing vaccine development and trials, again, something that public health is very involved with. And all of these things have been recognized by, as I mentioned, other people that work on neonatal herpes, and there are two papers, actually, at least two in the literature, that have called for making neonatal herpes a reportable disease for all of the reasons that we've been discussing. So this is a slide showing the number of visits in thousands made to physicians' offices for initial genital herpes diagnoses. And they have been steadily climbing since 1966. And this slide goes through 2013, when there were probably, looks like about 300,000 visits for genital herpes. Now, I wanted to show this slide because although we spoke earlier about the seroprevalence of genital herpes in New York City, this is a slide showing trends in the seroprevalence of genital herpes HSV2 in the U.S., stratified by race ethnicity and evidencing these huge racial disparities at the national level, not just the city level. So if you look at this solid black line on this curve, you see that between 1999, 2000, and 2015 or 16, which is the most recent set of NHANES data available, that the seroprevalence of HSV2 in this age-adjusted curve has declined steadily and over time to about 14%. But that is vastly different by race ethnicity subgroup, so that in the dotted line above, you see the seroprevalence of HSV2 among non-Hispanic blacks, and it also has declined, but it's still hovering as high as 38% nationally. So all of these data were taken into account when we considered making neonatal herpes reportable. And our argument in making the decision to make it reportable was really that we needed to have reliable and accurate measures of the disease burden. We wanted to be able to identify missed opportunities for prevention and to enable us to do systematic assessment of gaps in provider knowledge. We wanted to prepare for the eventual and anticipated eventual availability of a herpes vaccine and the ability then to monitor for the effectiveness of vaccine use. And we wanted to be able to detect outbreaks if there were any. So the actual process of making it reportable involved drafting a so-called certificate of necessity where we laid out our rationale for making it reportable, holding and presenting at 2 Board of Health meetings. And then finally, in April 2006, as a result of those meetings and the board's decision, neonatal herpes was made reportable in New York City. So a little more detail about what was required by the Board of Health. So at our first meeting in December 2005, we presented the proposal. The Board of Health authorized the publication of that proposal in the city record, which is a public means of communicating to the public about plans for the health board. Following the publication in the city record, there was a period of allowed for public comment, during which time any member of the public could submit a comment. It could be done online. It could be done. We held several hours long in-person listening session, and of course it could be written in any kind of submitted in any kind of written format, not just online. And after we had received public comment, we summarized all of those comments and responded to them and presented back to the Board of Health with the request that neonatal herpes be made reportable in March of 2006. And the decision made at that meeting by the board was that it could be. And then, in fact, neonatal herpes was made reportable in March of 2006. And as of that date, neonatal herpes was included in Section 1103 of the New York City Health Code, where all the diseases and conditions which must be reported by law in New York City are listed. And also in Section 11.05, where there are specifics about what clinical laboratories and healthcare providers must report to the City Health Department. And that was effective April of 2006. Now, one of the things that I didn't list as a consideration in making a disease reportable, but one that I do believe firmly in, is that you shouldn't make a disease reportable if you're not going to act on and use the information that you obtain as a result of its surveillance. And I want to take a moment to talk about how we have used neonatal herpes surveillance data, because we have used it a great deal. So far we have used it to assure adequate treatment for infected infants. We sometimes receive reports of cases that, when followed up, we determine the provider is either not aware yet of the case. Sometimes we receive the lab report before the provider does, or has not selected and initiated an appropriate treatment regimen, and so we're able to intervene. We have also used our surveillance data to assess the quality of administrative data, like hospital discharge data, as a means of surveillance. And actually, administrative data are pretty good for measuring, just crudely measuring, the disease burden. Of course, you get none of the detail. You get nothing about viral type. You don't get very good information on the vital status. Did the baby live or die? But I think what we've been able to show for jurisdictions where neonatal herpes is not reportable is that they can use administrative data as a crude measure of disease burden. I think the most powerful thing that we've done with the data is to educate healthcare providers across the city. I give a lot of grand rounds on neonatal herpes, and it's very useful to be able to present on the viral type distribution, the mortality rates in New York City. We have been able to examine delays in care seeking and in evaluation and treatment among these infants. We've been able to speak with providers about the adequacy of evaluation and treatment, and to educate them about the appropriate diagnosis and management of this disease. We've also used the data for targeted community education around direct or genital suction, and have been able to estimate quantify the risk associated with direct or genital suction in resulting in neonatal herpes. So I mentioned that we were able to compare our population-based surveillance data, to what we would measure in terms of disease burden if we used only administrative data. And this slide shows some of those findings, comparing data from 2006 to 2015 using, shown in blue, laboratory-confirmed surveillance cases that we identified through population-based surveillance, to those that we were able to identify in administrative data using ICD codes for herpes infection. And you can see that while the numbers are not exactly the same by year, they're very close, very close. And the same trends in disease are evident. So that when there are years where there are a high number of cases of surveillance cases, we sometimes will also see an increase in the administrative cases, as one might expect. So these are some of the characteristics of neonatal herpes cases reported through 2006 and 2015. Again, these are laboratory confirmed cases. And the column on the far left is all cases. You can see that there's been a male preponderance at about 55-56% of cases are male. There are the largest percent of cases is among mothers of Hispanic race ethnicity. And if you look at the viral type distribution, they're pretty evenly split between type 1 and type 2. We've had 16 cases over the years that were laboratory confirmed but didn't have viral type performed on the specimen. But I want to also call your attention to the column on the far right. These are the cases following ritual Jewish circumcision, which I will be speaking about in more detail. But I want to point out here that between 2006 and 2015 specifically, there were 13 such cases. They were all male, 13%. Not surprising, because circumcision obviously is a male infant procedure. They were 100% white, non-Hispanic, and they were 85% of them were herpes type 1. And those that weren't herpes type 1 were untyped. Now, these characteristics are not surprising for DOS cases because, to some extent, the case definition is a male infant with herpes type 1 infection following ritual Jewish circumcision. But I do want to show that we have had 13 cases meeting that case definition. In terms of the clinical syndrome that we have seen among babies, these again are data between 2006 and 2015, when we had a total of 120 laboratory confirmed cases. And you can see that overall, 45% of them have been skin, eye, and mucous membrane infection. About 20% have been CNS infection, 25% disseminated, and only 1.6% congenital. And there are an overall death rate, over in the far right column, overall death rate of 17.5%. Very low death rate among SEM cases at 1.8%, but disseminated cases, 60% death rate. Analysis of delays in care seeking and treatment, diagnosis and treatment have been very, very useful to present to healthcare providers in the city. We have seen that, about 21% of infants, there was a delay of more than 1 day between the first symptom and seeking attention from a medical provider. The median number of days was 2, but the range was as far out as 10 days. And this points to opportunities for educating mothers and parents generally about, things to look for in the newborn period. So that there aren't these delays. Then in terms of a delay in diagnosis, in 29% of cases, we found that there was more than 1 day between care seeking and the date that the first specimen was collected from an infant. And that was a median of 4 days, but with a range of 2 to 15. So this points to the importance of educating providers about recognizing neonatal herpes infection and testing as soon as you suspect it. But mostly, speaking to the need to suspect neonatal herpes infection. And then finally, the delay in initiating treatment with the appropriate antiviral regimen, which is acyclovir. We found that 20% of cases had more than 1 day between the day of specimen collection that ended up demonstrating herpes infection and starting treatment, with a median of 3 days, but a range as far out as 10 days. So the message here also for healthcare providers is like, if you're considering neonatal herpes to the point that you're actually testing for it, you should probably initiate treatment immediately. It's also been very useful to look at whether or not an appropriate workup was done. Babies where neonatal herpes is suspected should all have a lumbar puncture or spinal tap, and only 91% of the babies had that done. Liver function tests, or LFTs, should also always be done. Only 72% of the babies had that done. And only 50% overall had both a spinal tap and LFTs done. Appropriate treatment was given in only 73% of cases. Now, I do want to say that these past two slides, looking at care seeking and treatment initiation, and then the appropriate and adequacy of the workup, were taken from data that accrued in about the first 5 years of neonatal herpes surveillance. We have not repeated this analysis, and it's possible that things have gotten better. I certainly hope so, and probably we've done a lot of grand rounds. I certainly hope that has contributed to improvements in adequacy of workup. So I wanted to show you that in addition to population-based surveillance, we also educate providers with data we've examined from other sources. And these are data looking at deaths among infants in their first year of life due to herpes in the solid black, syphilis in the diagonal crosshatched, and then HIV in the lighter color. And of course, there were really many HIV deaths back in the late 80s and early 90s, and now they are extremely uncommon. And there was also a congenital syphilis outbreak, secondary to high rates of congenital syphilis in women back in the late 80s and early 90s. But if you look at what's gone on with herpes over this period of time in those black bars, you see that it's kind of steadily increased. Now, some of that, there are fewer deaths than from those other conditions at their peak. And some of the increase that we see in herpes may be due to the use of more sensitive diagnostic tests. So an ability to better discern a cause of death, and therefore to identify babies with herpes that may not have been so identified in the past. There's also been some changes in ICD coding that maybe have allowed for more specificity identifying deaths due to herpes. But this is something we want to keep in mind, because as herpes 1 becomes a more common cause of genital infection, we may see more and more herpes 1 deaths, so that despite the declines in herpes 2 among women of childbearing age nationally, that may be offset by increases in herpes 1. And so that we'll be reviewing these data as we move forward. Now I'm going to take a couple of minutes to talk about these cases that I have alluded to throughout the presentation, cases of neonatal herpes following ritual Jewish circumcision with direct orogenital suction. And this is a practice that occurs in some, not all, but in some ultra-Orthodox Jewish sects. These are cases I'm showing here that we published in the MMWR in June of 2012, showing the sort of relationship in the chronology of circumcision, development of herpes lesions in a set of what was then 11 cases. So what I want to show you is that these blue dots represent the day of circumcision, and these black squares represent when herpes lesions were noted, and these were all laboratory confirmed cases. And you can see that in every case, the incubation for neonatal herpes is thought to be about 2 to 12 days. And so in every case, herpes followed and did not precede circumcision. And in ritual Jewish circumcision and traditional Jewish practice, circumcision is performed on the 8th day of life. So these blue circles are all on the 8th day of life, and all of these cases followed and did not precede circumcision. And in one case, so two cases, where ritual Jewish circumcision was delayed for a reason of the baby being ill, perhaps having jaundice or some other cause, herpes lesions developed again within an incubation period following that delayed circumcision. Now, these are data for those same cases I showed on the previous slide. But let me take just a moment to say a bit more about the ritual Jewish circumcision practice. So during direct or genital suction, a moil, who is a ritual circumciser, removes the baby's foreskin with a scalpel. And in this practice of direct oral genital suction, ducks his head down and draws blood directly from the circumcision wound with his mouth. There's nothing between his mouth and the infant's freshly circumcised penis. He draws the blood into his mouth. And so what this slide shows is cases that occurred between, that we did some retrospective work and found a case from 2000, cases that we learned about in 2003 and 2004 and 5, and then those that we learned about between 2006 and 2011, because remember, herpes was made reportable in 2006. And so we show here the hospital where the baby was admitted, whether genital lesions were present, what the viral type was, whether the infant died, the clinical syndrome that they had, and the level of certainty that direct oral genital suction had been performed. Early on, parents were willing to say and disclose to healthcare providers that it had been performed. And then as time passed and the health department began to investigate cases to try to assure that there were no future exposures from a moil who had herpes 1 in his mouth, parents became less willing to disclose whether or not the procedure had been done. I want to start, though, by highlighting these two cases, case number 3 and 4. These were twin male infants born in 2004 who both presented to the hospital with genital lesions that were found to be type 1 within an incubation period of having been circumcised with direct oral genital suction by a single moil, listed here as moil A. And when one of these twins died, that's shown here, that twin A died very sadly. And when twin B was transferred to another hospital, one of the infectious disease attendings there recalled having gotten a phone call from a mother the year before asking whether it was possible for her infant to have acquired herpes type 1 as a result of ritual Jewish circumcision. And she contacted us, this ID attending contacted us and provided the phone number for that mother because she kept a phone log and was able to find that phone number. And when I called and spoke with the mother, I asked her who had performed her baby's circumcision, and she named the same moil who had performed this circumcision for these twins. So we then had a cluster of 3 cases of this really quite rare disease. We have, 125,000 live births in New York City a year. So roughly 60,000 of them are male. We only have about 15 cases of neonatal herpes, 15 at most 20 cases a year in all of New York City in 125,000 live births. So to have one moil associated in the span of 2 years with 3 cases is exceedingly unexpected. And we also want to call your attention to these sibling cases. In 2008, we had a case circumcised by a moil we refer to as moil X because we don't know that moil's name. That baby actually had central nervous system infection and serious damage as a result. And then in 2011, 3 years later, when the parents had another male infant, they hired back the same moil to perform that baby's circumcision, and that baby also got infected. So that's another cluster that we have in New York City. There's quite a bit of clinical and epidemiologic data to support the risk for herpes transmission during direct or genital suction. First of all, oral herpes 1 infection is largely asymptomatic, and as is the case with genital herpes, with oral herpes, viral shedding is intermittent and unpredictable. There's a very high prevalence in the U.S. of herpes simplex virus type 1 infection. I think I showed you that in New York it was 71% of people 20 and older. Herpes type 1 can be transmitted from the mouth of an infected person to the genitals of another. That has been demonstrated with the fact that genital herpes infections can be acquired due to type 1. During direct or genital suction, the adult mouth has direct contact with the infant penis, and circumcision definitely creates a break in skin integrity or the mucocutaneous barrier. These neonatal herpes infections occur within an incubation period of circumcision and are caused by herpes type 1. And the lesions occur at the site of oral exposure, that is the penis or scrotum, and or related dermatomes. And I'll say a little bit more about that. So this is a map of the dermatomes of the human body, and dermatomes are sections of skin on the body that are innervated by specific sensory nerves, peripheral sensory nerves. And this is predictable from person to person with maybe slight variations. But what's really interesting here, if you look at the nerves that serve the penis, S2 and S3, that's sacral nerve 2 and sacral nerve 3, you can see that they also serve the skin on the buttocks and the perianal area, and that S2, you see on the buttocks, actually serves the patch of skin that runs the length of the leg and goes down to the inner aspect of the ankle. And so what we've seen in cases of neonatal herpes following ritual Jewish circumcision with DOS, or direct or genital suction, is that babies will have lesions on the penis, but they'll also have lesions on the buttocks, and they will also have lesions on the inner aspect of their ankle. So that corresponds directly with inoculation of the skin that is served by sacral nerve 2, or S2. So that's been very interesting and a consistent observation. So to get back to the other evidence for an association, we have these clusters of cases associated with individual moiheleme. We have also published data that shows that this association between DOS and neonatal herpes, as well as the clustering around moiheleme, has been observed over time and across continents. It has been seen not just in the US and Canada, but also in Israel. And we also know that in the New York City's communities that do practice DOS, neonatal herpes infection occur only among males, and they're always herpes type 1. We don't see neonatal herpes infection among infant girls. And we have seen these sibling infections following circumcision by the same moil and these twin cases. But we don't see that outside of those communities. In terms of the contribution of these cases to our overall epidemiology, this is a figure showing lab-confirmed cases by year and sex. And the cases that follow DOS are in red. So you can see that among male cases, these DOS cases add, some years they've added 50% of cases. For example, in 2015, there were 4 DOS cases. No, sorry. That year there were 3 DOS cases. But in 2014, there were 5 DOS cases. And in that year, they made up more than half in 2014 and half in 2015 of all male neonatal herpes cases. So they contribute substantially. I think this slide shows it in another way. You look at female lab-confirmed neonatal herpes cases, and they're pretty evenly divided between the dark blue and the light blue. But if you look at the male, there's this preponderance of cases due to herpes type 1. When we remove those cases, the 17 cases that follow ritual Jewish circumcision from that time interval, 2006 through 2016, the male cases look very much like the female cases, pretty evenly split between type 1 and type 2. The data we have on these cases following direct or genital suction have very much informed the parent and provider education that we are able to deliver. We are distributing brochures called Have a Safe Bris to 8 hospitals in New York City, at which infants were either infants who acquired herpes during direct or genital suction were either born or subsequently hospitalized. These hospitals do this voluntarily because actually the state has jurisdiction over what hospitals do. But these 8 hospitals have voluntarily agreed to distribute brochures that we developed at delivery. We visit twice a year to confirm that they have the most recent brochure, to understand their current distribution strategy, because even though they're all giving it out at delivery, they're taking different approaches. And we've also developed posters that can be posted anywhere that the hospital sees fit, either on labor and delivery or on the postpartum ward. These brochures are available in English and in Yiddish and can be obtained by calling 311. We also have sent out an email to all New York City-based OBGYNs and pediatricians, informing them about this parental education effort and asking them to work with us to inform their patients. This is just to show you what the actual brochures look like. On the left is English and on the right is Yiddish. And the actual content of the brochure, which was developed in collaboration with City Hall, is shown here. Okay, again on the left in English and on the right in Yiddish. So in summary, neonatal herpes is a rare but serious disease. It is accompanied by significant morbidity and mortality, and there are few population-based data in the United States where we would expect, on the basis of genital herpes, to also observe regional differences in neonatal herpes. The changing epidemiology of genital herpes, as I mentioned earlier, in terms of the increase due to type 1, will very likely impact the epidemiology of neonatal herpes. At this time, prevention strategies are limited. Prenatal serologic screening does not appear cost-effective and is not currently recommended by any of the professional bodies. Vaccinating against genital infection will be the most effective means, but there is no effective vaccine yet. And of course, eliminating exposure to direct or genital suction could reduce some neonatal herpes cases on the order of 1 to 5 a year. Provider, parental, and community education regarding neonatal herpes is needed. Neonatal herpes surveillance in New York City has provided very valuable data. We use our data to describe the disease burden and the severity of infection among New York City infants, to discuss the natural history and possible prevention strategies, and eventually our data will allow us to evaluate the impact of vaccine. Most important, the surveillance process has provided information about neonatal herpes that provides data for action. This concludes my lecture. I hope it's been informative.